Island in Baltimore and Mercy Medical Center, and Bill is away today, so I'm going to be moderating today. We're very happy to have Dr. James from the Division of Maternal Fetal Medicine at UVA, and she is going to be talking to us about venous thromboembolism in pregnancy. I kind of muted that out. Anyway, Dr. James, take it away, and I'm going to take myself off of the camera, so away you go.
Hi, it's a pleasure to speak to you today about my favorite topic. My next favorite topic is bleeding, and I'll weave a little bit of that into the talk too, because if it weren't for bleeding, we wouldn't have this compensatory response. I have no disclosures relevant to this presentation. I was once complimented on the fact that I didn't have any pharmaceutical declarations, and I said I would gladly accept pharmaceutical support. It's just very difficult to get any pharmaceutical support for this kind of work or work in pregnancy. I'm going to cover the evolution relevant to thrombosis in pregnancy, the epidemiology of thrombosis in pregnancy, the relevant pathophysiology, risk factors for thrombosis in pregnancy, pharmacokinetics and pharmacodynamics of anticoagulation in pregnancy, diagnosis of new venous thromboembolism, and managing and preventing venous thromboembolism in pregnancy. Then I hope that you'll have specific questions that we can answer. So humans are mammals. They have a placenta, and consequently, at the time of delivery, when the placenta is expelled, it leaves a large space where the spiral arteries are exposed and the patient is at risk of bleeding. As a consequence, also, besides that bleeding from the uterus, there's also the risk of birth trauma. We are not chimpanzees. The human head coming through the pelvis and the soft tissue traumatizes the perineum, and besides, if the baby doesn't fit out, we do a cesarean delivery. The humans have evolved, human women have evolved to compensate for the bleeding challenges associated with pregnancy so that they are more hypercoagulable. This is a slide to remind me that pregnancy is a bleeding challenge. This is a cesarean hysterectomy. That's not a baby in the scale back there. That's a 13-pound, 4-ounce fibroid uterus. As a consequence of this evolutionary response, or this adaptive response to the bleeding challenges of pregnancy, women are hypercoagulable and they're at an increased risk of thrombosis. The incidence of venous thromboembolism in pregnancy is increased fourfold. The incidence of arterial thromboembolism is increased probably 3 to 4-fold. And what do I mean by arterial thromboembolism? I mean basically heart attacks and strokes. We almost never see peripheral arterial disease in pregnancy, such that the overall incidence of venous thromboembolism, depending on the series that has been published, is anywhere from 0.5 to 2 per 1,000 women. Now, pregnant women and women of childbearing age have healthy blood vessels, so only 20% of thromboembolic events are arterial and 80% are venous. And of these venous thromboembolic events, 75 to 80% occur in the deep veins, and 20 to 25% embolize and are embolize to the pulmonary circulation and our pulmonary emboli. During pregnancy, 10 to 12% of deep vein thrombosis, as opposed to outside of pregnancy, occur in the pelvis, 2% in the upper extremity, and 75 to 90% in the left lower extremity. This is in contrast to outside of pregnancy, where 99% of deep vein thrombosis occurs in the lower extremities. Now, and outside of pregnancy, deep vein thrombosis occurs in the lower extremities and occurs approximately equally in either extremity. So why the left lower extremity in pregnancy? Well, the clots that occur in pregnancy are occur under the influence of estrogen, and they are large, and they tend to be large iliofemoral clots. And these iliofemoral clots are subject to a pseudo-May-Thurner syndrome phenomenon, where there is compression of the right iliac artery by the left iliac vein, so they are more likely, this thromboembolism that occurs is more likely to occur in the left lower extremity than in the right. So it would seem then that perhaps that women would be more likely to suffer venous thromboembolism as pregnancy progresses. There's increased venous capacitance, there's mechanical obstruction by the growing uterus, there's decreased venous outflow, women are less mobile as pregnancy progresses, and there's increased vascular injury. But in fact, perhaps the risk of thrombosis occurs earlier in that, associated with hemostatic changes during pregnancy. And what are these hemostatic changes? Well, there's increase in fibrinogen, there's increase in factor 7, there's increase in factor 8, there's increase in factor 10, there's increase in von Willebrand factor, there's increase in Pi1, and Pi2 is actually made by the placenta. Not a big difference in factor 2, factor 5, factor 9. There's actually a decrease in the natural anticoagulant protein S, not a big change in protein C, and some changes in antithrombin that we'll talk about. So when you're looking for the right answer on the written boards, look for fibrinogen going up, factor 8 going up, von Willebrand factor going up, look for Pi2, look for protein S going down. But despite these anatomic changes that occur during pregnancy, the big risk factor is the big contributing factor are the hemostatic changes. And the hemostatic changes begin basically with the onset of pregnancy. And why would that be? Well, the bleeding challenges that occur during pregnancy begin with the onset of pregnancy, probably because of the risk of miscarriage. These data come from an epidemiologic study out of Norway. And here we have the incidence in venous thromboembolism by week. And as you look at these incidence data, it almost parallels the risk of bleeding during pregnancy. So you see an increase in the first trimester peaking around 8 weeks, and you see another increase in the mid-second trimester, and then you see a big increase postpartum, such that half of all venous thromboembolism occurs postpartum. not only does half of all venous thromboembolism occur postpartum, but half of postpartum venous thromboembolism occurs in the first 3 weeks postpartum. Not unexpectedly, that's where the big bleeding challenge is. It's at the time of delivery. But the risk of thromboembolism in pregnancy begins with pregnancy because bleeding challenges of pregnancy begin with pregnancy, even though the biggest challenge is at the time of delivery, such that women are 80 to 100 times more hypercoagulable in that first week postpartum. Now, we have some interesting, relatively new data from Mark Rogers' group out of Ottawa. He was looking for a marker of venous thromboembolism to use in studies of thromboprophylaxis postpartum. So he looked at MRI in women at high risk to develop thromboembolism postpartum and obtained MRIs on 15 women with risk factors for thrombosis who had had cesarean delivery. And he found that half of those women had definite evidence of thrombosis postpartum, and 2/3 had some evidence of thrombosis postpartum. These MRIs were obtained in the first 4 days after delivery. Well, that was somewhat stunning, a somewhat stunning finding. And he decided to look at women who were low risk for thromboembolism, i.e. women with no risk factors, or nothing we would consider a risk factor, who had had a spontaneous vaginal delivery. And he recently published those data. They were in the Gray Journal this past year. He looked at 30 women. Well, interestingly, in the first 4 days postpartum, those low-risk women had some evidence of thrombosis, the same rate of some evidence of thrombosis. 30% had definite evidence, and another 30% had some evidence of thrombosis. And that is very interesting data. Well, why would that be? Well, in all probability, thrombosis of the pelvic veins is probably one of the mechanisms by which normal involution occurs, that the veins, the small veins draining the placental site and the uterus itself thrombose in order to prevent exsanguination from the uterus. And if you remember back to cesarean deliveries you've done, I hope you can see my mouse here, you can probably remember that in times when you've had the uterus out, you've actually seen some clotting occurring in the broad ligament. We've looked obtained frequent measurements of antithrombin levels in postpartum women, about 24 normal postpartum women, and found apparent consumption of antithrombin with a nadir at 12 hours postpartum, and similar consumption in factor VIII levels at around the same time, suggesting that there is thrombosis going on somewhere in the body, presumably in the pelvis. So in most women, that process is curtailed and fibrinolysis kicks in and keeps that process under control. But some women go on, and a select few go on and thrombose their entire iliac vein and propagate it up into their inferior vena cava, like this woman did, who collapsed after a C-section and required immediate thrombectomy. And this is the clot we got out of her after that procedure occurred, and we were able to get this picture. So clearly there are risk factors for women who go on to have symptomatic thrombosis, symptomatic deep vein thrombosis, and symptomatic pulmonary embolism. Well, what are they? Well, the one that you're probably most familiar with, and the one that we pay the most attention, is a history of venous thromboembolism. And that is the most important risk factor for recurrent thromboembolism in pregnancy. With anticoagulation, we can significantly reduce that risk of thrombosis. Without thromboembolism, the risk of recurrent thrombosis is higher, anywhere from 2 to 12.5%. With anticoagulation, the risk is 1.5 to 5.5%. Excuse me, with anticoagulation, the risk of recurrent thrombosis is 1.5 to 5.5%. Without anticoagulation in a subsequent pregnancy, the risk is 2.5 to 12.5%. In the last decade or two, there have been significant attention to the risk factor of thrombophilia, or an inherited or acquired tendency to form clots. And I'm sure you're familiar with the factor V Leiden, prothrombin gene mutation, protein C, protein S, and amithrombin, all of which increase the tendency to form clots. These inherited risk factors, particularly if a patient has more than one, increase the risk of thrombosis. The absolute risk of thrombosis with any one of these risk factors may not justify thromboprophylaxis in pregnancy unless the patient herself has other risk factors, such as previous thrombosis, or is a homozygote or has compound heterozygosity. But there are additional acquired risk factors that may be apparent during the antepartum or postpartum period that can contribute to thrombosis, besides a history of thrombosis or an inherited or acquired thrombophilia, such as age over 35, which doubles the risk of thrombosis, smoking, anemia. That's counterintuitive, but perhaps patients with anemia have endogenous mechanisms in place that are helping to protect them against further blood loss. Preeclampsia increases the risk of thrombosis. Assisted reproductive technologies. And patients who develop thrombosis in that setting, those clots have a predilection for the upper extremity and the neck. Body mass index over 30, not a surprise. Multiple gestation. Sickle cell disease. Lupus. Immobility. And there's an interaction if there's also immobility and obesity. And these data were compiled by in the latest chapter on anticoagulation in pregnancy in the CHEST guidelines. Additional postpartum risk factors include C-section, but further compounded if there's emergency C-section. Preeclampsia, further compounded if there's fetal growth restriction. Postpartum infection, if there's cesarean Seems to be even more if it's with a vaginal delivery and if there's postpartum hemorrhage. Additionally, there's increased risk if there's a transfusion. Is transfusion just a marker for hemorrhage, or are there actually risk factors associated with the transfused red blood cells themselves that are less deformable, flow through the circulation less well, that have less nitric oxide, that are more hemolyzed, and hemoglobin, free hemoglobin itself is interacts with endothelium in a way that's thrombogenic. There was just a new epidemiologic study out of the United Kingdom from a large primary care database. It was published last month in the journal Blood and revealed some new risk factors for thromboembolism in pregnancy. Urinary tract infection doubles the risk. Pre-existing diabetes, not necessarily one we think of as a risk factor for thrombosis in pregnancy. Nephrotic syndrome shouldn't come as a surprise because that's a risk factor thrombosis outside of pregnancy. One that we don't always think of, inflammatory bowel disease, but it shouldn't come as a surprise because it's a risk factor outside of pregnancy. And postpartum, one we don't always think of, is stillbirth. But how did the patient come to have a stillbirth in the first place if she didn't have vascular risk factors? We talked about age as a risk factor for venous thromboembolism. The risk of venous thromboembolism doubles over the childbearing lifespan. There are racial differences. African American women have a 50% higher risk of venous thromboembolism than white or Hispanic women. And women with non-O blood group have a twofold higher increased risk of thromboembolism. And on a population basis, that's probably the most significant risk factor of all risk factors combined. So what do we do about it? Well, in pregnancy, to manage venous thromboembolism, we use anticoagulants. And we use them to treat thromboses, to prevent thromboses, and to try to improve the outcome of pregnancy. But there's some unique aspects about the pharmacokinetics and pharmacodynamics of anticoagulants in pregnancy. For one thing, maternal blood volume is increased 40 to 50%. There's an increased volume of distribution. There's increase in glomerular filtration and increased in renal excretion. There's increased in protein binding. And both heparin and low molecular weight heparin have shorter half-lives and lower peak plasma concentration. So higher doses are required, and generally more frequent administration is required. In the fetus, heparins do not cross the placenta, so at least we have an anticoagulant we can use. These are data from my former partner published. This was his fellow research project when he was at Pittsburgh, and he demonstrated, as you can see here, that during pregnancy, as compared to postpartum in the non-pregnant state, more heparin was required to achieve the same value, and heparin was, the half-life was shorter, and the time to peak concentration was less. And Holly Cassell demonstrated the same thing with enoxaparin. And you can see that basically this is the postpartum state. This is pregnant 12 to 15 weeks and 30 to 33 weeks. But after 12 hours, the enoxaparin is pretty much cleared from the circulation in a pregnant patient, which is our rationale for twice daily dosing during pregnancy. This is true of enoxaparin here, but I could put up the same slides for tinzaparin and dalteparin. So for heparins in general, there's no transplacental passage, which you're aware of. The disadvantages are it requires parenteral administration. There's a 1 to 2% risk of major bleeding. There's a risk of heparin-induced thrombocytopenia. And there's a risk of osteoporosis. There are published reports of vertebral fractures, and one report quoted a 2% risk of vertebral fracture. I had one patient who had a pelvic ramus fracture. There are reports anywhere from a 17 to 36% reduction in bone density. However, one has to keep in mind there are reductions in bone density in pregnancy, period. In randomized trials of patients who took prophylactic doses, there was a 2 to 2.5% reduced bone mineral density in patients who took unfractionated heparin compared to low molecular weight heparin, and that was no different. And in another randomized trial, which was low molecular weight heparin compared to controls, there was a 4% bone loss with low molecular weight heparin, which was identical in controls. So the bottom line is pregnant women lose some bone density, and it doesn't appear to be a lot different if they are on heparin, low molecular weight heparin, or neither. Just a comment about, this is a cartoon from the New England Journal 15 years ago, right, in a nice review article by Jeffrey Weitz. This cartoon illustrates the differences in unfractionated heparin compared to low molecular weight heparin. As you're aware, unfractionated heparin is, or low molecular weight heparin is chemically cleaved heparin, and both have the 5-pentasaccharide active sequence, but unfractionated heparin interacts with antithrombin and has activity against both factor 10 and thrombin, whereas low molecular weight heparin, because it's chemically cleaved, doesn't have this long tail, it only has activity against factor 10. And it explains why when we monitor low molecular weight heparin, we use anti-10A activity and not the PTT to monitor low molecular weight heparin. Low molecular weight heparin is the anticoagulant of choice for the management of venous thromboembolism in pregnancy and prevention of venous thromboembolism in pregnancy. It has the advantages of less bleeding than unfractionated heparin, much less bruising than unfractionated heparin. It has a longer half-life, has the lower risk of heparin-induced thrombocytopenia, fewer allergic reactions. I'd like to just say a couple things about those allergic reactions. It's not only the allergic reactions from the medication itself, but when we've had to use multi-dose vials with unfractionated heparin, those vials have become contaminated. We have to deal with the preservative. And for a few years ago, there was a problem with the heparin being contaminated with chondroitin sulfate because that the heparin was coming from China and was contaminated with chondroitin, and we had a number of serious allergic reactions. So it's not just the heparin that patients are reacting to, they're reacting to contaminants, bacterial, preservative, and otherwise that occur in the unfractionated heparin and in the multi-dose vials. So our low molecular weight heparin comes in nice single-dose syringes. We get a more predictable response than we do with unfractionated heparin. It's more convenient to administer. And there's no more bone loss than in controls. And as I emphasized, there's less likelihood of contamination. The disadvantage is it's more expensive. We may have to spend more time on the telephone with insurance companies, and it has a longer half-life. You already know that we don't use warfarin in pregnancy. As a rule, there are a few select circumstances where we might. In some cases, in mechanical heart valves, we may use it. In some cases where our hands are tied and we have no other therapeutic option. Because warfarin crosses the placenta, it increases the risk of miscarriage. There's, depending on the series, up to a 30% risk of birth defects. Even when it's taken after the period of organogenesis, there's a risk of fetal intracranial hemorrhage. And in one study where long-term outcomes of children exposed in utero were studied, there was a 14% rate of neurologic abnormality in the children exposed and a 4% rate of low IQ. So how do we diagnose venous thromboembolism during pregnancy? Well, not differently than we do outside of pregnancy now that we have compression ultrasound. The recommended initial test is ultrasound of the proximal veins with compression ultrasound. And if it's negative, and we suspect a clot higher up in the pelvis and in the iliac vein, we can do magnetic resonance venography. Now, if these patients come through the emergency room first, they may get a D-dimer, but D-dimers are almost always positive in pregnancy, and it's not particularly helpful. Also, there are cases of negative D-dimers when the patient actually had a venous thromboembolism or a pulmonary embolism in pregnancy. And in diagnosing new pulmonary embolism, both venous VQ scans and computed tomography pulmonary angiography give low fetal radiation. But radiation exposure with computed tomography, or CT, is associated with a 1 in 5,000 increased risk of developing breast cancer in the mother. However, the risk must be weighed against the risk of withholding the CT. Now, chest X-ray can be a discriminator. VQ scans are more likely to be diagnostic if chest X-ray is negative, and CTPA is more likely to be diagnostic if chest X-ray is abnormal. ACOG participated with the American Thoracic Society and the Society of Thoracic Radiology recently in developing clinical practice guidelines for diagnosing suspected pulmonary embolism in pregnancy, and these were published in the journal Radiology last year. And this algorithm is outlined here for the patient with suspected pulmonary embolism who has leg symptoms. If they should undergo compression ultrasound, if that's abnormal, then they should be treated. They can skip the any pulmonary workup. If they don't have leg symptoms, should undergo chest X-ray. If it's normal, VQ scan. If it's abnormal, CTPA. Now, if we actually diagnose venous thromboembolism in pregnancy, then what? Well, as I mentioned earlier, most of this venous thromboembolism or deep vein thrombosis in pregnancy is actually a big iliofemoral clot, and they consequently should be admitted. Or if they have a pulmonary embolism, they should probably be admitted. Besides, there are potentially fetal implications. If they're remote from delivery, and they have deep vein thrombosis, they can be started on low molecular weight heparin. If they have pulmonary embolism, some people are starting these patients on low molecular weight heparin, but there aren't a lot of data, and the gold standard is still intravenous heparin. Also, these patients may ultimately need another procedure like thrombolysis, and for that reason, intravenous heparin can be turned off if they need another procedure. Now, if delivery is imminent and they're going to need surgery imminently, a vena cava filter is a consideration, but that's the exception. Almost always these patients can be managed with anticoagulation. And we can't forget thrombolysis and for life or limb-threatening thrombosis. The risk of pregnancy loss in these cases is 8%, but if there is a life or limb-threatening thrombosis, it absolutely should not be withheld. Now, our practice bulletin from the American College of Obstetrics and Gynecology, practice bulletin number 123, has a detailed list of indications for full and low-dose anticoagulation. But here is a quick and dirty guideline for deciding who gets fully anticoagulated and who gets sort of low or medium dose anticoagulation. Generally, anybody who comes to you and is already fully anticoagulated, you can be pretty sure they probably have to stay fully anticoagulated. Anybody who has a current deep vein thrombosis or pulmonary embolism should probably stay fully anticoagulated. Needs to be started on full anticoagulation and continued. And patients who have venous thromboembolism and a high-risk thrombophilia. Patients who may not need to be fully anticoagulated and can get by on sort of a low or moderate dose include those who have a history of venous thromboembolism without high-risk thrombophilia, have the antiphospholipid syndrome without thrombosis, but they should also receive low-dose aspirin. Patients who have arterial thrombosis, but they should probably also have some low-dose aspirin for, in other words, an antiplatelet agent, and in some cases of inherited thrombophilia and poor pregnancy outcome. There are some patients who may only require close observation, i.e. those with a history of thrombosis in the presence of transient risk factors, whose event occurred in presence of transient risk factors and have no other risk factors, i.e. they don't have any, they're not morbidly obese, they don't have diabetes, they're not smokers, and they don't have any chronic venous insufficiency. Also, thrombophilia with no history of thrombosis, but these are patients we still may want to consider some short period of thromboprophylaxis in the early postpartum period. So how about, who do we consider postpartum thromboprophylaxis? Well, obviously anyone receiving thromboprophylaxis during pregnancy, remembering that cesarean delivery doubles the risk, but the risk remains low, and trials are all not adequately powered, it's reasonable to provide either mechanical or pharmacologic prophylaxis to patients with at least one additional risk factor. One decision analysis suggested mechanical prophylaxis was preferred due to decreased bleeding risk. Our ACOG practice bulletin states patients with multiple risk factors should receive both, and all patients undergoing cesarean should receive mechanical prophylaxis. So, in summary, we've covered how humans have evolved in a way that such that they're hypercoagulable. what the epidemiology of venous thromboembolism in pregnancy is, what the pathophysiology is, what the risk factors are, what the pharmacokinetics and pharmacodynamics are of the anticoagulants we routinely use in pregnancy, how we diagnose new venous thromboembolism, and just the skeleton of managing and preventing venous thromboembolism in pregnancy. And I want to thank you very much for your attention. I'd like to open it up for questions. I imagine there may be some specifics, but I didn't want to go into specifics of various protocols because every institution is different, and I'd rather field your questions. Thank you.
Can I ask about this one, the Antiphospholipid?
Yeah. Well,
Or somebody else is talking right now?
no, nobody's talking. What we have to do is the Q&A.
Yeah. I just
Here. Yeah. Dr. Horrible doctor. Horrible morning.
Prophylactic anticoagulation used in
Can you hear me, Dr. James?
I can.
Oh, I'm sorry. So we get a lot of patients who get referred and who had a sister who had a miscarriage, and then she got tested for factor V, and now you have a patient who comes, she has no history, and it feels like there's a lot of pressure because her a sister or a first-degree relative had a bad pregnancy outcome that we're obligated to give treatment. I just wanted to get your sense. I know that we do not give prophylactic anticoagulation, but thought I'd throw it out and see what your thoughts were.
Okay, so that's somebody, and I'm going to ask one more question because there are data to suggest that a family history of thrombosis increases the risk. This is somebody I'm going to ask about this particular hypothetical patient. I'm going to assume this patient is otherwise healthy. She has no other risk factors for thrombosis, and she herself, and she has no family history of thrombosis. She just has now, say, factor V Leiden based on her sister's poor pregnancy outcome.
Yes, that is correct.
Okay, so I try to reassure her. I would tell her, based on retrospective studies, her risk of thrombosis in pregnancy is less than 1%. Her risk of poor pregnancy outcome at most is double. A twofold risk of poor pregnancy outcome in a low-risk patient is still very low. We might entertain an extra ultrasound or two in the third trimester of pregnancy for reassurance, but that isn't particularly necessary. So, but she may find that reassuring an ultrasound at 28 weeks and 36 weeks, or maybe just 36 weeks. We know that our best pregnancy outcomes are to women who deliver at 39 weeks, because that's when the combined risk of stillbirth and newborn death are the lowest. So we would consider delivering her in that last week of pregnancy. We would consider extra testing if she went beyond that. Her risk of thrombosis is increased. Her risk of thrombosis is in the postpartum period, or her risk of thrombosis during pregnancy is about 1%, not enough to justify thromboprophylaxis, but is increased another fivefold after delivery. So that makes her risk about 5%. That is not enough to buy you thromboprophylaxis in Canada or Europe, but it is. My partners and I will consider thromboprophylaxis, for those, in fact, we usually prescribe, somebody who has factor V Leiden will give a daily injection of Lovenox 2 for 2 to 3 weeks. So that is the most we will do for that patient. An extra ultrasound or 2, avoiding post-dates, and weekly daily thromboprophylaxis for 3 weeks.
Okay. All right, we have a bunch of questions, and the first question is, thank you for a great presentation. Do you anticoagulate patients with massive proteinuria? Great question.
We have not been doing it during pregnancy unless they're hospitalized, and yes, we have been doing it for postpartum. Should we be doing it during pregnancy? Maybe, but we haven't been.
All right, next question. Why is prophylactic anticoagulation used in antiphospholipid syndrome?
Randomized trials to show that there is improved pregnancy outcomes.
How do you say it? No, they got it wrong. Can you get another edit? Okay.
All right, next question.
And that's Calchuck, and so the first randomized trial was Calchuck 1992.
No.
With the antiphospholipid?
Yes.
Okay.
And it was a randomized trial of heparin and low-dose aspirin compared to heparin and low-dose aspirin compared to prednisone and low-dose aspirin.
Right. All right, next question. For obese patients, there are more challenges with inadequate, the cedip-hlf results. Do you find better utility with the VieW scan in this population? I guess what they're asking is really some of these very obese patients, you have a hard time seeing distal pulmonary vessels.
Then we kind of wonder what the clinical significance is of those little distal vessels. And I don't have enough. I'd have to refer to somebody with more expertise than I do, like Lynn Horowitz, who was on our panel. Lynn was our CTPA expert on our ATS STR guideline. I'd have to refer to her. I just don't know enough. I'm sorry.
Well, that's okay. I mean, we certainly have our challenges, and whoever gave the question, I know we've had issues with really obese patients where we can't see the distal vessels well enough, and we have elected to not necessarily go to VieW scan because I think the sensitivities just aren't necessarily as good, and that's why we've moved over to the other. All right, and another question. Are you currently giving prophylactic anticoagulation to all your morbidly obese patients postpartum or post-cesarean?
Okay, this is a superb question because we are just we tried to make that decision at Duke before I left. We're trying to make that decision at UVA here. We are now participating in an NIH and Canadian Institute of Health funded randomized trial called the PROSPER study, which is largely trying to figure out whether women would agree to be randomized in a study of postpartum thromboprophylaxis. But we're trying to figure out which patients we should not randomize who would not be candidates for this study. How obese are you so that you should be opted out of the study because you're so obese you should be mandated thromboprophylaxis. And this week we've decided that if you have a BMI over 50, you should automatically get prophylaxis. Should it be 40? I don't know. But we had a maternal death this year in a woman with a BMI over 50, so this week it's 50.
Thromboprophylax anybody that's normal.
Okay.
What was that?
I think I heard someone thromboprophylax anyone who's pregnant. How about if you take the morbidly obese?
There was someplace I was talking to somebody who came here from Minnesota in nursing, and she said they did mechanical and pharmacologic prophylaxis for anybody who had a C-section. We just had a paper in Thrombosis research where we showed that our wound complication rate was 7% in patients without thromboprophylaxis, 30% in women with thromboprophylaxis or anticoagulation treatment. So I don't want everybody with a C-section to get thromboprophylaxis. Go ahead. Pharmacologic, that is.
I was going to ask you in regard to your high-risk patients who are on bed rest who are morbidly obese, and certainly we can certainly argue this week about obesity and bed rest or bed rest in general. But currently, someone's in the hospital who's got PPROM with a breach, who's morbidly obese. What are you doing, mechanically, or are you giving heparin in these morbidly obese? I think we're all stuck with this major concern for thrombosis in anyone who is immobile, as your slides showed, in regard to risk.
So if you look at the actual relative risks that were compiled in the American College of Chest Physicians for that particular group, the morbidly obese patient on bed rest for more than a week, her risk of a thromboembolism is increased 60-fold. That seems like that buys you thromboprophylaxis. Have we necessarily moved to that? I mean, that buys you more than just mechanical prophylaxis. Have we necessarily done that here yet? It's like we almost need Wiki or Wells criteria. We need a calculator. We need to be able to put everything in, and because these risk factors are multiplicative, they're not just additive. We increase the risk of thrombosis. Okay, when we put in all those things that you said, they multiply. And do we necessarily do that? I think we were led astray when we looked at the inpatient data from the from our national U.S. data, and we found no increased risk of thrombosis among patients who were admitted for preterm labor or premature rupture of membranes. So that led us astray, thinking, okay, these patients were likely at bed rest for a week or so, and they weren't demonstrating an increased risk of thrombosis. With more refined data from Norway, they found that yes, when you put patients to bed for more than a week, they are at increased risk of thrombosis, particularly when you multiply factors on top like obesity, hypertension, etc. Have we decided how we're going to manage them during pregnancy? Not yet. But certainly they certainly qualified for this study that we're participating in, and it's caused me to rethink just which patients need to be thromboprophylaxis. And you could certainly justify thromboprophylaxis, meaning pharmacologic thromboprophylaxis, besides pneumatic compression devices for those patients while they're at bed rest. And then in the Norwegian data, it was bed rest for a week or more that put them at risk.
Yeah, I think this is good. I think everyone on the line who's watching this will be very interested over the next months to years to determine exactly what agent, what patient population to do this. I think the risks are quite high, and having this kind of trial will be very important. So if I hear you right, a BMI of greater than 50 is automatic, both compression and pharmacologic.
Yes, and that's our opinion this week.
Yeah.
That's how firm that is.
Well, maybe you can get us, Dr. James, when it finally goes through and gets funded, if it gets funded, hopefully. Right now it's just a pilot study. It's been funded by the NIH and Canadian Institute of Health, but we hope it'll be enough compelling that and enough people will participate that we'll have a larger trial. Well, that's great. Are there any other questions before we say goodbye and thank Dr. James so much for her time and great lecture? I'll give you another couple seconds. And if not, I do not have the next lecture. I don't know if we're taking the summer off or not, there will be some information that's provided to you through emails for all of the fellowship directors as it comes.
I had a question.
Okay, go ahead. Sure. State where you're from.
We're calling from Cedar Sinai. The question that I wrote earlier was incomplete. It's asking why is it prophylactic for antiphospholipid, and the question really was trying to ask why is it prophylactic versus full anticoagulation, because if they have the syndrome, that means that they must have had some personal history or event that caused them to have the syndrome. So why are they not fully anticoagulated?
So if they qualify for the syndrome based on poor pregnancy outcome, they get a low dose. If they qualify because they have a personal history of a thromboembolic event, venous or arterial, then they would get a full dose.
And if they had arterial, you'll add them on aspirin?
Yes.
Okay. Thank you.
And if it's poor pregnancy outcome, they get a low dose plus an aspirin.
Okay.
So if I heard you correct, Dr. James, you are when you're using prophylactic Lovenox, you are using twice daily.
That's my preference based on Holly Cassell's data that's been replicated with other low molecular weight agents.
Yeah, I think that's sort of one of those things that has come over time where, people are now doing that. But I'd be interested to hear if anyone still on the line on the lecture is only using once a day. And I think your compelling evidence through your graphs clearly shows that once a day dosing is not enough. And I think before her data came out, I had several patients who ended up clotting off even with once a day dosing.
Well, I will mention one of the greatest proponents of once-a-day dosing and for prophylaxis or treatment was Saskia Middeldorp from Amsterdam, who's one of our world's leading thrombosis epidemiologists. And she compiled all the data from Holland on recurrence risks for thrombosis in pregnancy. And they had a 5.5% recurrence risk when they used single dose low dose prophylaxis in Holland or in the Netherlands. They had a 5.5% rate, and so she's proposed a high-low study, randomizing people between low dose and full dose, because she now believes that particularly single low dose, is not enough in pregnancy because a 5.5% recurrent rate is in the same range as the rate we get with no prophylaxis.
Yeah. All right. Well, Dr. James, thank you so much for volunteering your time. We really appreciate all the work you're doing, and thank you, everyone. And you'll get emails in the future as to when the next lectures are. So, everyone, have a great day.
Thank you very much.